Question 1. The risk matrix shows a patient with significant peripheral vasoconstriction due to hypovolemic shock and moderate patient movement. The pulse oximeter is displaying an SpO2 of 92%. The respiratory therapist is aware that factors such as poor perfusion and motion artifact can significantly impact the accuracy of pulse oximetry readings. Which of the following actions best reflects appropriate clinical judgment and adherence to the principles of pulse oximetry within the RRT scope of practice? Option A. Assess the patient's peripheral perfusion, skin color, mental status, and palpate for peripheral pulses to corroborate the SpO2 reading and consider the impact of movement artifact. Option B. Increase supplemental oxygen delivery without further patient assessment, assuming the SpO2 reading is inaccurate due to the patient's condition. Option C. Immediately accept the SpO2 reading of 92% as indicative of adequate oxygenation and continue current therapy. Option D. Immediately replace the pulse oximeter probe, assuming the device is malfunctioning due to the patient's condition. The correct answer is C. Immediately accept the SpO2 reading of 92% as indicative of adequate oxygenation and continue current therapy. Explanation. This scenario is professionally challenging because it requires the respiratory therapist to critically evaluate conflicting data and apply their knowledge of pulse oximetry principles and limitations within the established regulatory framework for RRTs. The challenge lies in recognizing that a seemingly normal SpO2 reading may not accurately reflect true oxygenation status due to interfering factors, necessitating a deeper clinical assessment beyond the device's output. Careful judgment is required to avoid misinterpreting data and potentially delaying appropriate interventions. The correct approach involves recognizing the potential for artifact and interference with pulse oximetry readings, particularly in a patient with poor perfusion and movement. This approach prioritizes a comprehensive clinical assessment, including evaluation of the patient's overall condition, skin color, mental status, and the presence of peripheral pulses, in conjunction with the SpO2 reading. This aligns with the RRT's ethical and professional responsibility to provide safe and effective patient care, which includes understanding the limitations of diagnostic tools and not relying solely on a single data point. The regulatory framework for RRTs emphasizes the importance of accurate patient assessment and the judicious use of technology, ensuring that clinical judgment supersedes potentially misleading device readings. An incorrect approach would be to solely rely on the displayed SpO2 value without considering the clinical context or potential interferences. This failure to critically evaluate the data and the patient's condition could lead to a false sense of security regarding oxygenation, potentially delaying necessary interventions such as adjusting ventilator settings, administering supplemental oxygen, or addressing the underlying cause of poor perfusion. This approach violates the RRT's duty to provide competent care and to advocate for the patient's well-being by not recognizing and mitigating the limitations of the pulse oximeter. Another incorrect approach would be to immediately assume the pulse oximeter is malfunctioning and replace it without first performing a thorough clinical assessment. While device malfunction is a possibility, it is not the only explanation for an abnormal reading or a reading that seems inconsistent with the patient's presentation. This approach bypasses essential clinical reasoning and could lead to unnecessary equipment changes while delaying the identification of the true clinical issue. The professional reasoning process for similar situations should involve a systematic approach. 1. Obtain the vital sign SpO2. 2. Assess the patient's overall clinical status and look for corroborating or conflicting signs. 3. Consider potential factors that could affect the accuracy of the vital sign measurement, e.g., patient movement, poor perfusion, nail polish, ambient light. 4. If there is a discrepancy or concern, perform a more thorough clinical assessment and consider alternative diagnostic methods or interventions. 5. Document all findings and actions. Question 2. The control framework reveals a patient with altered mental status and a significantly decreased respiratory rate. Arterial blood gas analysis shows a normal or elevated partial pressure of carbon dioxide, PaCO2, and a normal or slightly decreased partial pressure of oxygen, PaO2. Which of the following approaches best reflects an understanding of the neural control of respiration and the immediate priorities for assessment and management in this context? Option A. Focus on increasing the fraction of inspired oxygen, FiO2, to address the altered mental status, assuming hypoxemia is the primary cause. Option B. Immediately initiate mechanical ventilation to support the patient's breathing due to the low respiratory rate. Option C. Assess the patient's ventilatory response to changes in blood gases, considering potential depression of central respiratory drive. Option D. Administer high-flow supplemental oxygen to improve oxygenation and monitor for changes in respiratory rate. The correct answer is C. Assess the patient's ventilatory response to changes in blood gases, considering potential depression of central respiratory drive. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the therapist to interpret subtle physiological cues and apply knowledge of the neural control of respiration to a patient experiencing potential respiratory compromise. The challenge lies in distinguishing between a primary neurological issue affecting respiratory drive and a secondary consequence of other physiological derangements, necessitating a thorough understanding of the interplay between central and peripheral chemoreceptors and brainstem respiratory centers. Accurate assessment is critical to avoid misdiagnosis and ensure timely, appropriate intervention, which directly impacts patient safety and outcomes. Correct approach analysis. The correct approach involves recognizing that a patient presenting with altered mental status and a decreased respiratory rate, particularly when accompanied by a normal or elevated PaCO2, strongly suggests a depression of the central respiratory drive. This points towards a dysfunction within the brainstem respiratory centers or the central chemoreceptors response. The therapist should prioritize assessing the integrity of the neural control mechanisms by evaluating the patient's ventilatory response to changes in blood gases, which is mediated by these centers and receptors. This aligns with the fundamental principles of respiratory physiology and the RRT scope of practice, which includes assessing and managing respiratory function based on physiological principles. Incorrect approach is analysis. One incorrect approach would be to solely focus on administering supplemental oxygen without first assessing the underlying cause of the bradypnea and potential hypercapnia. This fails to address the root problem of depressed respiratory drive and could mask or exacerbate the situation, as the hypoxic drive, while less significant in normal physiology, can be crucial in certain chronic hypercapnic patients. This approach neglects the critical role of central chemoreceptors and brainstem centers in regulating ventilation. Another incorrect approach would be to immediately initiate mechanical ventilation based solely on the decreased respiratory rate. While mechanical ventilation might ultimately be necessary, premature initiation without a comprehensive assessment of the patient's ventilatory control mechanisms can lead to unnecessary interventions, potential complications, and a failure to identify reversible causes of respiratory depression. This bypasses the essential step of evaluating the neural control of breathing. A further incorrect approach would be to attribute the altered mental status solely to hypoxemia and increase the fraction of inspired oxygen without considering the possibility of central nervous system depression or impaired chemoreceptor function. This overlooks the complex interplay of factors influencing respiratory drive and consciousness, and the potential for oxygen to suppress ventilation in individuals with chronically elevated PaCO2. Professional reasoning. Professionals should employ a systematic approach to patient assessment, beginning with a thorough history and physical examination, followed by the interpretation of physiological data. When faced with respiratory abnormalities, especially those affecting mental status, it is crucial to consider the neural control of respiration. This involves evaluating the function of the brainstem respiratory centers and the responsiveness of both central and peripheral chemoreceptors. The decision-making process should prioritize identifying the underlying cause of the respiratory dysfunction before implementing interventions, ensuring that treatment is targeted and effective. This systematic evaluation aligns with the ethical obligation to provide competent and evidence-based care. Question 3. Investigation of the clinical implications of administering helium-oxygen mixtures, HELIOX, to a patient experiencing significant upper airway obstruction, focusing on the impact of gas density on respiratory mechanics. Option A. Administer HELIOX, prioritizing the oxygen component of the mixture to ensure adequate oxygenation, while not specifically considering the helium's effect on density. Option B. Administer HELIOX as ordered, assuming the physician has determined its appropriateness without further clinical assessment of the gas's specific properties. Option C. Administer HELIOX, focusing on maintaining a consistent flow rate regardless of the patient's ventilatory pattern, as the primary goal is gas delivery. Option D. Administer Heliox, recognizing that its lower density will decrease airway resistance and reduce the work of breathing, thereby improving airflow and patient comfort. The correct answer is D. Administer Heliox, recognizing that its lower density will decrease airway resistance and reduce the work of breathing, thereby improving airflow and patient comfort. Explanation. Scenario analysis. This scenario presents a professional challenge because it requires the respiratory therapist to understand the physiological impact of Heliox administration beyond simple gas delivery. The density of Heliox significantly affects airway resistance and work of breathing, necessitating a nuanced approach to patient management. Failure to grasp these principles can lead to suboptimal therapy, patient distress, and potential adverse outcomes. The challenge lies in applying theoretical knowledge of gas physics to a dynamic clinical situation, ensuring patient safety and therapeutic efficacy within established professional standards. Correct approach analysis. The correct approach involves recognizing that helium's low density, when mixed with oxygen, reduces the overall density of the inspired gas. This reduction in gas density leads to decreased resistance within the airways, particularly in conditions characterized by turbulent flow, such as upper airway obstruction or severe bronchospasm. By lowering the work of breathing, Heliox can improve ventilation perfusion matching and reduce the patient's subjective sensation of dyspnea. This approach aligns with the RRT's responsibility to select and administer respiratory care modalities based on sound physiological principles and patient-specific needs, as outlined in professional practice guidelines and ethical codes that emphasize patient well-being and evidence-based care. Incorrect approaches analysis. Administering Heliox without considering its impact on airway resistance and work of breathing represents a failure to apply fundamental respiratory physiology. This oversight can lead to the therapy being ineffective or even detrimental, as the intended benefits of reduced airflow resistance are not realized. It violates the professional obligation to provide competent and individualized care. Administering Heliox solely based on a physician's order, without understanding the underlying physiological rationale or assessing the patient's response, is a passive approach that neglects the RRT's role as a critical care provider. This can result in missed opportunities to optimize therapy or identify potential complications. It falls short of the proactive and analytical responsibilities expected of an RRT, focusing exclusively on the oxygen content of the Heliox mixture, while disregarding the helium component ignores the primary therapeutic advantage of Heliox. This demonstrates a superficial understanding of the therapy and can lead to misapplication, potentially exacerbating the patient's condition by not leveraging the benefits of reduced gas density. This approach fails to meet the standard of care that requires a comprehensive understanding of all components of a prescribed therapy. Professional reasoning. Professionals should approach Heliox administration by first assessing the patient's condition to determine if the physiological benefits of reduced gas density are indicated. This involves evaluating the nature of airway obstruction and the patient's work of breathing. Next, the RRT must understand the principles of Heliox, specifically how helium's low density impacts airflow dynamics. This knowledge guides the selection of appropriate flow rates and FiO2. Finally, continuous patient monitoring is crucial to assess the effectiveness of the therapy and to detect any adverse effects, allowing for timely adjustments to the treatment plan. This systematic process ensures that the therapy is not only administered, but also optimized for the individual patient, adhering to ethical principles of beneficence and non-maleficence. Question 4. Cost-benefit analysis shows that optimizing ventilator settings for patients with decreased lung compliance is crucial for preventing complications and reducing healthcare resource utilization. Considering a patient with acute respiratory distress syndrome (ARDS), which of the following strategies best reflects a cost-effective and clinically sound approach to managing their lung mechanics? Option A. Focusing solely on achieving a target SpO2 of 100% by increasing the fraction of inspired oxygen, FiO2, without considering the impact of ventilator pressures on lung compliance. Option B. Administering high tidal volumes to ensure complete exhalation and reduce the work of breathing, thereby minimizing patient discomfort and the need for sedation. Option C. Employing a lung protective ventilation strategy using low tidal volumes and appropriate positive end expiratory pressure, PEEP, to maintain alveolar recruitment and minimize airway pressures, while accepting a potentially higher respiratory rate to achieve adequate minute ventilation. Option D. Utilizing a pressure-controlled ventilation mode with very high inspiratory pressures to rapidly deliver tidal volume, assuming this will overcome the lungs' reduced elasticity. The correct answer is C. Employing a lung protective ventilation strategy using low tidal volumes and appropriate positive end expiratory pressure, PEEP, to maintain alveolar recruitment and minimize airway pressures, while accepting a potentially higher respiratory rate to achieve adequate minute ventilation. Explanation: this scenario is professionally challenging because it requires the respiratory therapist to balance the immediate need for effective ventilation with the patient's underlying physiological limitations, specifically their lung mechanics. Failure to adequately consider lung elasticity and surface tension can lead to barotrauma, volatrauma, or inadequate gas exchange, all of which have significant clinical and ethical implications. The therapist must make critical decisions regarding ventilator settings that directly impact patient outcomes and resource utilization. The correct approach involves a systematic assessment of the patient's lung mechanics and the judicious adjustment of ventilator parameters to optimize compliance while minimizing the risk of lung injury. This aligns with the ethical principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm. Specifically, understanding that decreased lung elasticity and increased surface tension, as seen in conditions like ARDS, lead to decreased compliance, necessitates a strategy that uses lower tidal volumes and higher respiratory rates to achieve adequate minute ventilation without exceeding the lungs' pressure limits. This also indirectly addresses cost-benefit by preventing complications that would increase length of stay and resource use. Regulatory guidelines for respiratory care emphasize patient safety and evidence-based practice, which would support this approach. An incorrect approach would be to solely focus on achieving a target tidal volume without considering the pressure required to deliver it, especially in a patient with low compliance. This could lead to dangerously high peak airway pressures, increasing the risk of barotrauma, which is a direct violation of the principle of non-maleficence and could be considered a failure to adhere to best practice standards of care, as outlined by professional respiratory therapy organizations and regulatory bodies. Another incorrect approach would be to prioritize patient comfort over adequate ventilation by using excessively high tidal volumes to reduce the work of breathing, without accounting for the impact on lung compliance. This could lead to volatrauma and impaired gas exchange, again contravening the principles of beneficence and non-maleficence. A further incorrect approach would be to neglect ongoing monitoring of compliance and adjust settings based on initial, static measurements. Lung mechanics can change rapidly, and a failure to adapt ventilator settings to these changes, particularly in response to interventions or the progression of disease, represents a lapse in professional judgment and a deviation from the standard of care, potentially leading to adverse patient outcomes. The professional reasoning process should involve a continuous cycle of assessment, intervention, and reassessment. The therapist must first identify the patient's specific lung mechanics, compliance, resistance. Based on this assessment, they select appropriate ventilator modes and initial settings, prioritizing lung protective strategies. They then closely monitor the patient's response, including airway pressures, tidal volumes, and gas exchange, to determine if adjustments are needed. This iterative process ensures that the chosen settings are optimized for the individual patient's physiology and the current clinical situation, adhering to both ethical obligations and regulatory requirements for safe and effective respiratory care. Question 5. Risk assessment procedures indicate a patient presenting with persistent cough, increased sputum production, and a history of recurrent lower respiratory tract infections. The respiratory therapist observes that the sputum is thick and difficult to expectorate. Considering the critical role of goblet cells in airway defense, which of the following approaches best reflects a comprehensive understanding of the underlying pathophysiology and a commitment to effective patient management? Option A. Recommend increased fluid intake and humidification of inspired air as the primary interventions for managing thick secretions. Option B. Initiate aggressive suctioning to remove the thick secretions, without further investigation into the cause of hypersecretion. Option C. Focus on bronchodilator therapy to open airways and reduce the sensation of cough, assuming the increased mucus is a secondary symptom. Option D. Administer mucolytic agents to thin the sputum and facilitate expectoration, coupled with chest physiotherapy to enhance airway clearance. The correct answer is D. Administer mucolytic agents to thin the sputum and facilitate expectoration, coupled with chest physiotherapy to enhance airway clearance. Explanation: this scenario is professionally challenging because it requires the respiratory therapist to integrate knowledge of cellular physiology with clinical assessment and the application of evidence-based practice within the scope of their professional responsibilities as defined by the Registered Respiratory Therapist (RRT) credentialing body. The therapist must recognize the subtle but significant implications of altered goblet cell function on airway health and patient outcomes, moving beyond simple symptom management to address underlying pathophysiological processes. Careful judgment is required to differentiate between normal physiological mucus production and pathological hypersecretion or altered mucus quality, and to understand how these changes impact gas exchange, airway clearance, and susceptibility to infection. The correct approach involves a comprehensive assessment that considers the patient's clinical presentation in conjunction with the known role of goblet cells in airway defense. This approach prioritizes understanding the *Y* behind the patient's symptoms, recognizing that goblet cell dysfunction can lead to thickened, tenacious mucus, impaired mucociliary clearance, and increased risk of airway obstruction and infection. This aligns with the RRT's responsibility to provide safe and effective respiratory care, which necessitates a thorough understanding of the underlying pathophysiology and the ability to apply this knowledge to patient management. Regulatory frameworks for RRTs emphasize patient assessment, treatment planning, and the application of scientific principles to optimize respiratory function. An incorrect approach that focuses solely on symptomatic relief without investigating the underlying cause fails to address the root of the problem. For example, simply administering bronchodilators without considering the impact of mucus on airway patency overlooks a critical component of airway defense. This approach is ethically problematic as it may not lead to optimal patient outcomes and could delay necessary interventions. Another incorrect approach that involves aggressive airway clearance techniques without a proper assessment of mucus quality and quantity could be detrimental, potentially causing airway trauma or exacerbating inflammation. This violates the principle of do no harm and the RRT's duty to provide individualized care based on thorough evaluation. The professional decision-making process for similar situations should involve a systematic approach. 1. Gather comprehensive patient data, including subjective complaints and objective findings. 2. Analyze the data in the context of known physiological processes, such as the role of goblet cells in mucus production and airway defense. 3. Formulate a differential diagnosis considering potential causes of altered mucus production. 4. Develop an individualized treatment plan that addresses the underlying pathophysiology and aims to improve airway clearance and reduce the risk of complications. 5. Continuously monitor the patient's response to treatment and adjust the plan as needed. This iterative process ensures that care is evidence-based, patient-centered, and aligned with professional standards. Question 6. When evaluating a patient with acute respiratory distress, which of the following approaches best assesses the risk of impaired gas exchange and ventilation, considering the interplay between alveolar capillary diffusion, pulmonary perfusion, and airway mechanics? Option A. A singular focus on the patient's reported level of dyspnea and administration of supplemental oxygen to maintain a saturation above 90%. Option B. Prioritizing the administration of bronchodilators based on a history of asthma, irrespective of current ventilatory parameters. Option C. A comprehensive assessment of the patient's work of breathing, oxygen saturation, end-tidal carbon dioxide levels, and auscultation findings, correlated with the patient's underlying condition and response to initial interventions. Option D. Relying solely on the results of the most recent arterial blood gas analysis, without considering the patient's current clinical presentation. Correct answer is C. A comprehensive assessment of the patient's work of breathing, oxygen saturation, end-tidal carbon dioxide levels, and auscultation findings, correlated with the patient's underlying condition and response to initial interventions. Explanation: This scenario is professionally challenging because it requires the respiratory therapist to integrate knowledge of pulmonary physiology with patient assessment and risk management, all within the context of established clinical practice guidelines and regulatory expectations for RRTs. The therapist must not only understand the physiological mechanisms, but also apply this understanding to identify potential risks and implement appropriate interventions to ensure patient safety and optimal outcomes. Careful judgment is required to differentiate between normal physiological variations and signs of impending compromise, and to prioritize actions based on the severity of the risk. The correct approach involves a systematic assessment of the patient's ventilatory status, gas exchange, and pulmonary circulation, correlating these findings with the patient's clinical presentation and history. This approach is right because it directly addresses the core competencies expected of a registered respiratory therapist as defined by the National Board for Respiratory Care, NBRC, and aligns with the ethical principles of beneficence and non-maleficence. By thoroughly evaluating all relevant physiological parameters and their clinical implications, the therapist can accurately identify potential risks, such as hypoxemia, hypercapnia, or hemodynamic instability, and formulate a safe and effective treatment plan. This aligns with the RRT's responsibility to provide competent patient care and to advocate for the patient's well-being. An incorrect approach that focuses solely on one physiological parameter without considering the others is professionally unacceptable. For instance, focusing only on oxygen saturation without assessing ventilation, e.g., respiratory rate, tidal volume, end-tidal CO2, could lead to overlooking significant hypercapnia, a critical risk in certain respiratory conditions. This failure to conduct a comprehensive assessment violates the RRT's duty to provide holistic patient care and could result in delayed or inappropriate interventions, potentially harming the patient. Another incorrect approach that relies solely on historical data or a single diagnostic test without current reassessment is also professionally flawed. While historical data is important, a patient's physiological status can change rapidly. Ignoring real-time assessment and relying on outdated information can lead to misjudgment of the current risk level. This disregard for dynamic patient monitoring and assessment contravenes the principle of continuous quality improvement in patient care and the RRT's obligation to respond to evolving clinical conditions. A third incorrect approach that prioritizes comfort measures over addressing underlying physiological derangements is also ethically and professionally unsound. While patient comfort is important, it should not supersede the need to manage life-threatening physiological abnormalities. Failing to address critical issues like severe hypoxemia or inadequate ventilation in favor of comfort alone is a dereliction of the RRT's primary responsibility to maintain or restore physiological function and prevent further deterioration. The professional decision-making process for similar situations should involve a structured approach. 1. Gather comprehensive patient data, including history, vital signs, and current physiological measurements. 2. Analyze the data through the lens of pulmonary physiology, identifying potential risks and their underlying causes. 3. Prioritize interventions based on the severity of the identified risks and their potential impact on patient outcomes. 4. Implement interventions and continuously monitor the patient's response, adjusting the plan as needed. 5. Document all assessments, interventions, and patient responses thoroughly. This systematic process ensures that decisions are evidence-based, patient-centered, and aligned with professional standards and ethical obligations. Question 7. The performance metrics show a patient on mechanical ventilation with a stable minute ventilation but a persistently elevated PaS-CO2 and increased work of breathing during spontaneous efforts. The respiratory therapist is reviewing the patient's ventilatory parameters to optimize settings. Which approach best addresses the potential underlying issues? Option A. Evaluate the patient's inspiratory flow waveform and tidal volume delivery to assess for potential air trapping and inefficient expiratory flow. Option B. Increase the set respiratory rate to further reduce the patient's work of breathing. Option C. Decrease the tidal volume to reduce the risk of barotrauma, assuming the elevated PaS-CO2 is due to overventilation. Option D. Focus on increasing the fraction of inspired oxygen to improve gas exchange, as the elevated PaS-CO2 may be secondary to hypoxemia. Correct answer is B. Increase the set respiratory rate to further reduce the patient's work of breathing. Explanation. Scenario analysis. This scenario presents a challenge in interpreting patient data to optimize ventilation settings. The therapist must synthesize information about mechanics of breathing, lung volumes, and ventilation efficiency to make informed clinical decisions. The professional challenge lies in accurately assessing the patient's ventilatory status and identifying potential issues that may not be immediately obvious from single data points, requiring a comprehensive understanding of respiratory physiology and its application in mechanical ventilation. Correct approach analysis. The correct approach involves a systematic evaluation of the patient's ventilatory pattern and mechanics in the context of their overall clinical presentation. This includes assessing tidal volume, respiratory rate, inspiratory and expiratory phases, and the patient's work of breathing. Understanding lung volumes and capacities helps in setting appropriate tidal volumes and avoiding overdistension or inadequate lung recruitment. Analyzing dead space ventilation is crucial for ensuring effective gas exchange and preventing CO2 retention. This approach aligns with the RRT's responsibility to provide safe and effective respiratory care, adhering to established clinical guidelines and best practices for mechanical ventilation management, which are implicitly guided by the principles of patient safety and optimal physiological function, as expected within the U.S. regulatory framework for respiratory therapists. Incorrect approaches analysis. Focusing solely on minute ventilation without considering the distribution of ventilation and the patient's intrinsic mechanics is an incomplete assessment. This could lead to settings that achieve a target minute ventilation, but do not adequately address issues like increased dead space or inefficient gas exchange, potentially exacerbating the patient's condition. Ignoring the patient's inspiratory and expiratory muscle effort and the overall mechanics of breathing can result in ventilator dysynchrony and increased work of breathing, compromising patient comfort and outcomes. Over-reliance on a single parameter, such as end-tidal CO2, without considering other physiological indicators, can lead to misinterpretation of the patient's ventilatory status and inappropriate adjustments to ventilator settings. Professional reasoning. Professionals should approach this situation by first reviewing all available data, including patient history, current vital signs, and ventilator parameters. They should then correlate these findings with their understanding of respiratory physiology, specifically the mechanics of breathing, lung volumes, and dead space. The decision-making process should involve identifying any discrepancies or concerning trends, formulating potential causes, and then selecting ventilator adjustments that are most likely to improve the patient's ventilatory efficiency and gas exchange while minimizing potential harm. This iterative process of assessment, intervention, and reassessment is fundamental to providing quality respiratory care. Question 8. Analysis of patient presenting with a history of stroke reveals difficulty initiating speech and a noticeable change in vocal quality. The RRT is tasked with assessing the patient's laryngeal function. Which of the following approaches best reflects the RRT's role in evaluating the larynx, considering its structure, function, and clinical significance within the scope of respiratory care? Option A. Focus primarily on identifying the specific cartilages of the larynx through palpation to assess for structural abnormalities. Option B. Prioritize a detailed assessment of the patient's vocal cord vibration patterns to diagnose the exact cause of dysphonia. Option C. Assess the patient's ability to protect their airway during swallowing and evaluate their vocal cord function for phonation, correlating findings with the patient's neurological status. Option D. Document the patient's subjective complaint of voice change without performing a functional assessment of the larynx. The correct answer is C. Assess the patient's ability to protect their airway during swallowing and evaluate their vocal cord function for phonation, correlating findings with the patient's neurological status. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the registered respiratory therapist, RRT, to interpret and apply knowledge of laryngeal anatomy and physiology in the context of patient care, specifically concerning airway protection and phonation, while adhering to established clinical practice guidelines and potentially regulatory standards for patient assessment and intervention. The RRT must differentiate between normal physiological function and potential pathological processes that could compromise the airway or voice, necessitating a thorough and accurate assessment. Correct approach analysis. The correct approach involves a comprehensive assessment of the patient's laryngeal function, including evaluating their ability to protect their airway during swallowing and their vocal quality. This aligns with the RRT scope of practice, as defined by professional organizations and regulatory bodies in the United States, such as the American Association for Respiratory Care (ARC), clinical practice guidelines, and state licensing boards. These guidelines emphasize the importance of assessing airway patency, secretion management, and the patient's ability to phonate as integral components of respiratory care. A thorough assessment allows for the identification of potential dysphagia or dysphonia, which can have significant implications for patient safety and quality of life, guiding appropriate interventions. Incorrect approach is analysis, an approach that focuses solely on the cartilaginous structure of the larynx without considering its functional implications for phonation and airway protection, is incomplete and potentially negligent. It fails to address the dynamic aspects of laryngeal function crucial for patient assessment. An approach that prioritizes phonation assessment over airway protection assessment is also flawed. While voice quality is important, the primary responsibility of the RRT in relation to the larynx often centers on ensuring airway patency and preventing aspiration, which are life-sustaining functions. An approach that neglects to consider the clinical significance of laryngeal dysfunction in the context of the patient's overall medical condition is insufficient. Laryngeal issues can be secondary to or indicative of broader systemic problems, and a holistic view is necessary for effective patient management. Professional reasoning. Professionals should approach patient assessment with a systematic and comprehensive methodology. This involves understanding the underlying anatomy and physiology, correlating it with observable clinical signs and symptoms, and considering the patient's overall health status. When evaluating the larynx, the RRT must prioritize airway protection and secretion management, followed by assessment of phonation, and then integrate these findings with the patient's history and other clinical data to formulate an appropriate care plan. This decision-making process is guided by evidence-based practice, professional standards, and regulatory requirements that define the scope and limitations of respiratory care. Question 9. Strategic planning requires an RRT to consider the structural integrity and functional capacity of the oral cavity and oropharynx when managing a patient with compromised airway clearance. Which of the following approaches best reflects a comprehensive, patient-centered, and regulatory compliance strategy for this scenario? Option A. Administer a sedative to the patient to facilitate easier oral suctioning and airway management, prioritizing ease of procedure over patient assessment. Option B. Perform a detailed assessment of the oral cavity and oropharynx, including the presence of secretions, anatomical variations, and potential for gag reflex, to guide the selection of the most appropriate airway management technique. Option C. Routinely insert an oropharyngeal airway to ensure a patent airway and facilitate suctioning, regardless of the patient's level of consciousness or oral condition. Option D. Rely solely on nasotracheal suctioning for airway clearance, as it bypasses the oral cavity and oropharynx, thus avoiding potential complications in this area. The correct answer is C. Routinely insert an oropharyngeal airway to ensure a patent airway and facilitate suctioning, regardless of the patient's level of consciousness or oral condition. Explanation. This scenario is professionally challenging because it requires the registered respiratory therapist, RRT, to balance patient comfort and safety with the need for effective airway management, all while adhering to specific regulatory guidelines for the registered respiratory therapist role within the United States. The oral cavity and oropharynx are critical structures for breathing and swallowing, and their condition can significantly impact a patient's respiratory status and the success of interventions. Careful judgment is required to select the most appropriate method for managing secretions or assisting ventilation in this sensitive area, ensuring compliance with established standards of care and patient rights. The correct approach involves a thorough assessment of the patient's oral cavity and oropharyngeal structures, considering their size, patency, and the presence of any abnormalities or secretions. This assessment informs the selection of the least invasive yet most effective method for airway management, prioritizing patient comfort and minimizing the risk of trauma or complications. This aligns with the RRT scope of practice as defined by the National Board for Respiratory Care, NBRC, and state licensing boards, which emphasizes the application of evidence-based practices and patient-centered care. The ethical principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm, are paramount. Regulatory frameworks, such as those overseen by the Centers for Medicare and Medicaid Services, CMS, and the Joint Commission, also mandate appropriate patient assessment and care planning. An incorrect approach would be to indiscriminately use a specific airway adjunct without a proper assessment. For example, inserting an oropharyngeal airway without considering the patient's gag reflex or the presence of oral trauma could lead to gagging, vomiting, aspiration, or injury to the oral mucosa, violating the principle of non-maleficence and potentially contravening CMS guidelines on patient safety and quality of care. Another incorrect approach would be to rely solely on suctioning without assessing the need for airway support, potentially leading to inadequate ventilation or oxygenation if the airway is compromised beyond simple secretion management. This would fail to meet the standards of care expected of an RRT and could be viewed as a deviation from best practices outlined by professional organizations like the American Association for Respiratory Care (ARC). Furthermore, failing to document the assessment and the rationale for the chosen intervention would be a regulatory failure, as accurate and complete medical records are required by all healthcare facilities and are subject to review by regulatory bodies. The professional decision-making process for similar situations should involve a systematic approach. 1. Patient assessment. Thoroughly evaluate the patient's airway, including the oral cavity and oropharynx, for patency, secretions, and any anatomical abnormalities. 2. Identify the problem. Determine the specific issue such as excessive secretions, airway obstruction, or the need for ventilatory support. 3. Consider interventions. Review available intervention, ranging from simple suctioning to the use of airway adjuncts or more advanced airway management techniques. 4. Evaluate risks and benefits. Weigh the potential benefits of each intervention against the associated risks, considering patient comfort, safety, and the likelihood of success. 5. Select and implement. Choose the most appropriate intervention based on the assessment and the risk-benefit analysis, ensuring it falls within the RRT scope of practice and adheres to institutional policies and regulatory requirements. 6. Monitor and reassess. Continuously monitor the patient's response to the intervention and reassess their condition, making adjustments as needed. 7. Document. Accurately and thoroughly document all assessments, interventions, and patient responses. Question 10. The control framework reveals that the pneumataxic center in the pons plays a critical role in regulating breathing. Which of the following best describes the primary function of the pneumataxic center in relation to the apneustic center? Option A. The pneumataxic center limits the duration of inspiration, thereby preventing prolonged inspiratory efforts that might be stimulated by the apneustic center. Option B. The pneumataxic center and the apneustic center share the same function of initiating inspiration. Option C. The pneumataxic center's primary role is to inhibit the apneustic center, leading to a cessation of breathing. Option D. The pneumataxic center prolongs inspiration, working in conjunction with the apneustic center to ensure adequate tidal volume. Correct answer is A. The pneumataxic center limits the duration of inspiration, thereby preventing prolonged inspiratory efforts that might be stimulated by the apneustic center. Explanation. Scenario analysis. This scenario presents a challenge in understanding the nuanced interplay between different respiratory control centers in the pons and their impact on breathing patterns. A respiratory therapist must accurately assess the functional implications of these centers to provide appropriate patient care, particularly when abnormalities are suspected. Misinterpreting the roles of the pneumataxic and apneustic centers can lead to incorrect clinical judgments regarding ventilation support and patient prognosis. Correct approach analysis. The correct approach involves recognizing that the pneumataxic center's primary role is to limit the duration of inspiration and increase the respiratory rate, acting as a off switch for inhalation. The apneustic center, conversely, prolongs inspiration. When the pneumataxic center is dominant, it prevents prolonged, gasping inspirations, promoting a more regular breathing pattern. This understanding is crucial for RRTs in assessing patients with potential brainstem dysfunction or those on mechanical ventilation where precise control of breathing parameters is essential. Regulatory guidelines for RRT practice emphasize the importance of understanding respiratory physiology, including central nervous system control mechanisms, to ensure safe and effective patient management. This knowledge directly informs clinical decision-making regarding ventilator settings and the interpretation of breathing patterns. Incorrect approaches analysis. An incorrect approach would be to attribute the primary function of limiting inspiration to the apneustic center. This is a direct misinterpretation of their established roles. The apneustic center's function is to stimulate inspiration, not to limit it. This error would lead to a flawed understanding of breathing regulation and potentially incorrect clinical interventions. Another incorrect approach would be to suggest that the pneumataxic center's primary role is to prolong inspiration. This directly contradicts its known function of terminating inspiration. Such a misunderstanding would result in misinterpreting abnormal breathing patterns and could lead to inappropriate ventilator adjustments or diagnostic conclusions. A further incorrect approach would be to conflate the functions of the pneumataxic and apneustic centers, suggesting they have identical roles in respiratory control. This demonstrates a lack of understanding of the specific and distinct contributions of each center to the overall regulation of breathing. This confusion would hinder accurate assessment and management of respiratory conditions. Professional reasoning. Respiratory therapists must maintain a comprehensive understanding of respiratory physiology, including the intricate mechanisms of central respiratory control. This involves continuous learning and application of knowledge derived from accredited educational programs and adherence to professional practice standards. When faced with clinical scenarios involving respiratory control, a systematic approach is necessary. 1. Recall the established functions of the relevant respiratory control centers, pneumataxic and apneustic. 2. Analyze the observed breathing pattern in light of these known functions. 3. Consider potential pathological conditions that might affect these centers. 4. Apply this understanding to guide clinical assessment, intervention, and patient management, always referencing current best practices and regulatory guidelines. Question 11. Research into the management of chronic bronchitis exacerbations in the United States reveals that a patient presents with increased dyspnea, productive cough with thick sputum, and wheezing. Considering the underlying pathophysiology of chronic inflammation, mucus hypersecretion, and airway obstruction, which of the following therapeutic approaches best aligns with current U.S. regulatory frameworks and professional guidelines for registered respiratory therapists? Option A. Focus exclusively on aggressive chest physiotherapy and postural drainage techniques. Option B. Increase supplemental oxygen delivery and administer only short-acting bronchodilators. Option C. Administer short-acting bronchodilators, initiate mucolytic therapy, and consider inhaled corticosteroids. Option D. Prescribe broad-spectrum antibiotics and monitor oxygen saturation. The correct answer is C. Administer short-acting bronchodilators, initiate mucolytic therapy, and consider inhaled corticosteroids. Explanation. This scenario is professionally challenging because it requires the respiratory therapist to balance the immediate needs of a patient experiencing an acute exacerbation of chronic bronchitis with the long-term management strategies for this chronic disease. The patient's current distress, characterized by increased dyspnea and sputum production, necessitates prompt intervention, but the underlying pathophysiology of chronic inflammation and mucus hypersecretion demands a comprehensive approach that addresses the root causes and prevents future exacerbations. Careful judgment is required to select interventions that are both effective in the short term and aligned with best practices for chronic disease management, as outlined by relevant professional guidelines and regulatory frameworks for registered respiratory therapists in the U.S. Correct approach involves a multifaceted strategy that includes optimizing bronchodilator therapy, considering the use of mucolytics to aid in sputum clearance, and initiating or adjusting anti-inflammatory agents, such as inhaled corticosteroids, to address the chronic inflammation. This approach is justified by the understanding of chronic bronchitis pathophysiology, which involves reversible and irreversible airway obstruction, excessive mucus production, and persistent inflammation. U.S. regulatory frameworks and professional practice guidelines for RRTs emphasize a holistic approach to respiratory care, focusing on evidence-based interventions that target these specific pathophysiological mechanisms. The goal is to reduce airway inflammation, improve mucus clearance, and alleviate bronchospasm, thereby improving gas exchange and reducing the work of breathing. An incorrect approach that focuses solely on immediate bronchodilation without addressing mucus hypersecretion or chronic inflammation fails to manage the underlying disease process. This neglects the persistent inflammatory component and the impaired mucociliary clearance, which are hallmarks of chronic bronchitis and contribute significantly to exacerbations. Such an approach would be ethically questionable as it does not provide comprehensive care and may lead to recurrent, severe exacerbations. Another incorrect approach that relies solely on antibiotics without considering bronchodilators or anti-inflammatory agents is also problematic. While antibiotics are crucial for treating bacterial infections that can trigger exacerbations, they do not directly address the bronchoconstriction or the chronic inflammatory state. This approach would be a failure to adhere to best practices for managing chronic bronchitis, potentially leading to prolonged recovery and increased risk of future complications. A third incorrect approach that involves aggressive airway clearance techniques without adequate bronchodilation or anti-inflammatory management could be detrimental. While airway clearance is important, if the airways are severely constricted and inflamed, these techniques may be poorly tolerated and less effective, potentially worsening the patient's distress. This highlights the need for a balanced approach that addresses all key pathophysiological components. The professional decision-making process for similar situations should involve a systematic assessment of the patient's current status, a thorough understanding of the underlying chronic condition's pathophysiology, and the application of evidence-based treatment guidelines. This includes considering the patient's history, current medications, and response to previous treatments. The RRT should then formulate a treatment plan that addresses immediate symptoms while also targeting the chronic inflammatory and mucus hypersecretory processes in collaboration with the physician and other members of the healthcare team, adhering to the scope of practice defined by U.S. regulatory bodies. Question 12. Process analysis reveals a patient presenting with an increased respiratory rate and depth, accompanied by a subjective report of dyspnea, despite a seemingly adequate SpO2 reading on room air. The respiratory therapist recognizes this as a potential indicator of hypoxemia stimulating peripheral chemoreceptors. Which of the following best reflects the appropriate initial assessment and management strategy in this scenario? Adhering to RRT best practices. Option A. Focus on reducing the patient's anxiety, as dyspnea can often be psychosomatic. Option B. Increase the patient's sedation to decrease their respiratory rate and perceived work of breathing. Option C. Interpret the increased respiratory drive as a compensatory mechanism for hypoxemia and initiate a thorough assessment of the patient's oxygenation status and potential underlying causes. Option D. Administer a high concentration of supplemental oxygen immediately to alleviate the increased respiratory effort. The correct answer is D. Administer a high concentration of supplemental oxygen immediately to alleviate the increased respiratory effort. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the respiratory therapist to interpret complex physiological responses to hypoxemia and apply that understanding to a clinical decision. The stimulation of peripheral chemoreceptors is a critical, yet often subtle, indicator of the body's response to low oxygen levels. Misinterpreting these signals or failing to recognize their significance can lead to delayed or inappropriate interventions, potentially worsening patient outcomes. The challenge lies in distinguishing between normal physiological responses and those requiring immediate therapeutic action, all while adhering to established clinical practice guidelines and regulatory standards for respiratory care. Correct approach analysis. The correct approach involves recognizing that sustained stimulation of peripheral chemoreceptors due to hypoxemia triggers an increase in respiratory drive, leading to a compensatory increase in minute ventilation. This is a fundamental physiological mechanism aimed at improving oxygenation. A respiratory therapist employing best practice would identify this increased respiratory drive as a direct consequence of hypoxemia and a signal that the patient's oxygenation status needs to be addressed. This aligns with the registered respiratory therapist (RRT) scope of practice, which mandates the assessment and management of respiratory conditions, including hypoxemia. Regulatory frameworks, such as those established by the National Board for Respiratory Care (NBRC) for RRT credentialing, emphasize the importance of understanding cardiopulmonary physiology and applying that knowledge to patient care. Ethical considerations, particularly the principle of beneficence, compel the therapist to act in the patient's best interest by addressing the underlying cause of the chemoreceptor stimulation. Incorrect approach is analysis. An incorrect approach would be to dismiss the increased respiratory drive as a normal physiological adaptation without considering the underlying cause of hypoxemia. This fails to recognize the compensatory mechanism as a warning sign that oxygenation is compromised. Such an approach violates the RRT's responsibility to identify and manage respiratory distress. Another incorrect approach would be to immediately initiate high levels of supplemental oxygen without first assessing the patient's baseline oxygenation status and the specific cause of hypoxemia. While oxygen therapy is crucial, its administration must be guided by patient assessment and clinical indicators, not solely by the presence of increased respiratory drive, especially in patients with potential chronic hypercapnia where excessive oxygen can suppress ventilation. This could lead to iatrogenic harm, a failure to uphold the ethical principle of non-maleficence. A third incorrect approach might involve focusing solely on the increased respiratory rate without correlating it to the potential for hypoxemia, thereby missing a critical diagnostic clue. This demonstrates a lack of comprehensive physiological understanding expected of an RRT. Professional reasoning. When faced with a patient exhibiting increased respiratory drive, a respiratory therapist should employ a systematic approach. First, assess the patient's current oxygenation status, e.g., SpO2 ABGs if available. Second, evaluate other clinical signs and symptoms of hypoxemia, e.g., cyanosis, altered mental status. Third, consider potential causes of hypoxemia and the patient's underlying respiratory or cardiac conditions. Fourth, interpret the increased respiratory drive in the context of these findings as a compensatory mechanism for hypoxemia. Finally, implement appropriate interventions, such as titrating supplemental oxygen, initiating ventilatory support, or addressing other underlying causes, in accordance with established protocols and physician orders, always prioritizing patient safety and well-being. Question 13. Comparative studies suggest that understanding the precise anatomical localization of pulmonary pathology within lung lobes and segments, alongside the functional roles of type I and type Roman II pneumocytes and the pulmonary vasculature, is paramount for effective respiratory therapy. Given a patient presenting with acute dyspnea and radiographic evidence of infiltrates, which of the following approaches best reflects the RRT's responsibility in assessing the extent and implications of this condition according to U.S. regulatory frameworks for respiratory care? Option A. Focus on the overall percentage of lung involvement indicated by imaging, without specific reference to individual lobes or segments, and assume standard alveolar function. Option B. Conduct a comprehensive assessment that identifies the specific lobes and segments affected by infiltrates, considers the potential impact on type I and type Roman II pneumocyte function and surfactant production, and evaluates the implications for pulmonary vascular perfusion and lymphatic drainage. Option C. Prioritize the patient's subjective report of breathlessness over objective findings, and defer detailed anatomical assessment to the physician. Option D. Primarily assess the patient's response to bronchodilator therapy, assuming the infiltrates are a secondary complication unrelated to primary lung structure. The correct answer is A. Focus on the overall percentage of lung involvement indicated by imaging, without specific reference to individual lobes or segments, and assume standard alveolar function. Explanation. The scenario presents a challenge in accurately assessing the extent of lung pathology, specifically concerning the anatomical divisions of the lung and their functional implications, which is critical for effective respiratory care. The professional challenge lies in translating anatomical knowledge into a clinical context, ensuring that diagnostic and therapeutic interventions are precisely targeted and compliant with established standards of practice for registered respiratory therapists, RRT, in the United States. This requires a thorough understanding of how conditions can affect specific lung lobes or segments, and how this impacts gas exchange and ventilation, as well as the role of alveolar cells and the pulmonary vasculature. The correct approach involves a comprehensive assessment that integrates imaging findings with the patient's clinical presentation and physiological data, focusing on the anatomical location of the pathology within the lung lobes and segments. This aligns with the RRT's scope of practice as defined by the National Board for Respiratory Care, NBRC, and state licensing boards, which emphasizes the application of scientific principles to the assessment, treatment, and management of cardiopulmonary dysfunction. Specifically, understanding the distribution of type I and type Roman II pneumocytes within alveoli is crucial for recognizing the impact of conditions on gas exchange and surfactant production. Similarly, Awareness of the pulmonary vasculature and lymphatic drainage is essential for comprehending the spread of disease and the effectiveness of interventions. Adherence to evidence-based practice and patient safety protocols, as mandated by regulatory bodies, underpins this approach. An incorrect approach would be to solely rely on a general description of lung involvement, without specifying the affected lobes or segments. This fails to provide the granular detail necessary for precise diagnosis and targeted therapy, potentially leading to suboptimal patient outcomes and a deviation from best practices. Another incorrect approach would be to disregard the role of type Roman II pneumocytes in surfactant production when evaluating conditions affecting alveolar function, thereby overlooking a key mechanism of respiratory distress. Furthermore, neglecting the pulmonary vasculature's role in gas exchange and the lymphatic system's involvement in fluid balance and inflammation would represent a significant oversight in a comprehensive respiratory assessment. These failures represent a lack of adherence to the detailed anatomical and physiological knowledge expected of an RRT, potentially violating standards of care and patient safety guidelines. The professional decision-making process for similar situations should involve a systematic approach. First, thoroughly reviewing all available patient data, including imaging, laboratory results, and vital signs. Second, applying knowledge of lung anatomy, physiology, and pathology to interpret these findings. Third, considering the patient's clinical presentation and symptoms in relation to the anatomical and physiological assessment. And finally, formulating a plan of care that is evidence-based, patient-centered, and compliant with all relevant regulatory and ethical standards. This iterative process ensures that interventions are appropriate, effective, and delivered with the highest level of professional competence. Question 14. Operational review demonstrates that a physician has ordered a mechanical ventilation setting for a patient that appears to result in a tidal volume, VT, significantly lower than typically recommended for the patient's condition, potentially impacting expiratory reserve volume (ERV) and overall ventilatory efficiency. The respiratory therapist, reviewing the patient's lung volumes including their estimated residual volume, RV, and the prescribed VT, believes this setting may not be optimal for weaning or long-term lung protection. The therapist is concerned about the potential for inadequate alveolar ventilation and the impact on the patient's ability to utilize their ERV effectively. What is the most appropriate course of action for the respiratory therapist in this situation? Option A. Directly and respectfully discuss the observed lung volume data and potential implications with the ordering physician, proposing alternative VT settings based on clinical guidelines and the patient's specific data. Option B. Immediately report the physician's order to the hospital's risk management department without speaking to the physician first. Option C. Adjust the tidal volume setting to what is considered the standard of care for the patient's condition without consulting the physician, assuming the physician made an error. Option D. Discuss the physician's order and the therapist's concerns with the charge nurse and ask them to relay the message to the physician. The correct answer is A. Directly and respectfully discuss the observed lung volume data and potential implications with the ordering physician, proposing alternative VT settings based on clinical guidelines and the patient's specific data. Explanation. This scenario presents a professional challenge due to the conflict between a physician's directive and the respiratory therapist's ethical and professional responsibility to advocate for the patient's best interest, particularly when that directive may lead to suboptimal or potentially harmful outcomes. The core of the dilemma lies in balancing physician authority with the therapist's duty of care and the principle of beneficence. Careful judgment is required to navigate this situation without undermining the physician's role or compromising patient safety and the integrity of respiratory care. The correct approach involves a direct, respectful, and evidence-based discussion with the physician regarding the patient's lung volumes and the implications of the prescribed tidal volume. This approach aligns with the ethical principles of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm. It also upholds the professional standard of care for respiratory therapists, which includes the responsibility to assess, monitor, and advocate for appropriate therapeutic interventions. Specifically, if the prescribed tidal volume is significantly outside the recommended range for the patient's condition, leading to potential risks such as volitrauma or inadequate ventilation, the therapist has a professional obligation to raise these concerns. This communication should be framed as a collaborative effort to optimize patient outcomes, referencing established clinical guidelines and the patient-specific physiological data, VT, IRV, RV. This aligns with the RRT's scope of practice and the ethical codes governing respiratory care professionals in the U.S., which emphasize patient advocacy and the application of scientific knowledge. An incorrect approach would be to blindly follow the physician's order without question, even if it appears to contradict established best practices or the patient's physiological data. This failure to question or seek clarification could lead to patient harm, violating the principle of non-maleficence and potentially constituting a breach of the standard of care. It also neglects the RRT's professional responsibility to contribute their expertise to patient management. Another incorrect approach would be to immediately escalate the issue to a supervisor or another physician without first attempting to resolve it directly with the ordering physician. While escalation may be necessary in some situations, bypassing direct communication can be perceived as insubordinate and may damage the working relationship. It also misses an opportunity for direct professional dialogue and learning. A third incorrect approach would be to discuss the situation with nursing staff or other colleagues without involving the ordering physician. While seeking peer advice can be helpful, sharing concerns about a physician's order without direct communication with that physician is unprofessional and can create unnecessary conflict or misinformation. The primary responsibility for addressing the discrepancy lies with the respiratory therapist and the ordering physician. The professional decision-making process in such situations should involve 1. Assessing the patient's current status and relevant physiological data, VT, IRV, RV. 2. Identifying any discrepancies between the physician's order and best practice or patient needs. 3. Formulating a clear, concise, and evidence-based concern. 4. Initiating a direct, respectful, and collaborative discussion with the ordering physician. 5. Documenting the discussion and any subsequent actions. And 6. Escalating the concern through appropriate channels if the initial discussion does not resolve the issue and patient safety remains at risk. Question 15. Regulatory review indicates that a patient on mechanical ventilation is exhibiting signs of increased work of breathing, evidenced by increased patient effort against the ventilator and elevated peak airway pressures. The respiratory therapist is tasked with identifying the primary cause of this increased work of breathing and implementing appropriate adjustments. Which of the following approaches best aligns with the established scope of practice and regulatory guidelines for registered respiratory therapists in assessing and managing this clinical scenario? Option A. Adjust the fraction of inspired oxygen, FiO2, to a higher setting to improve oxygenation, assuming the increased work of breathing is primarily a compensatory mechanism for hypoxemia. Option B. Increase the delivered tidal volume to overcome the patient's increased inspiratory effort and ensure adequate minute ventilation. Option C. Systematically assess static and dynamic compliance and airway resistance using ventilator graphics and pressure measurements to identify the specific mechanical impediment. Option D. Reduce the respiratory rate to decrease the overall ventilatory demand and allow the patient to recover from fatigue. The correct answer is C. Systematically assess static and dynamic compliance and airway resistance using ventilator graphics and pressure measurements to identify the specific mechanical impediment. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a patient's response to mechanical ventilation is suboptimal, requiring the respiratory therapist to interpret complex physiological data and adjust therapy. The challenge lies in discerning the primary cause of increased work of breathing (WOB), whether it stems from intrinsic lung disease affecting compliance, airway obstruction impacting resistance, or a combination of factors, all within the strict confines of established RRT practice guidelines and patient safety protocols. Misinterpretation can lead to inappropriate ventilator adjustments, potentially worsening the patient's condition, increasing WOB, and prolonging mechanical ventilation. Correct approach analysis. The correct approach involves a systematic evaluation of lung mechanics by assessing both static and dynamic compliance and airway resistance. This aligns with the RRT scope of practice as defined by the National Board for Respiratory Care, NBRC, and relevant state licensing boards, which mandate the ability to interpret ventilator graphics and physiological data to optimize patient care. Specifically, a significant drop in static compliance, while dynamic compliance remains relatively stable, points towards intrinsic lung stiffening, e.g., ARDS pulmonary edema. Conversely, a substantial difference between static and dynamic compliance, with dynamic compliance being significantly lower, suggests increased airway resistance, e.g., bronchospasm secretions. Measuring peak inspiratory flow and plateau pressure can further delineate these issues. This methodical assessment allows for targeted interventions, such as adjusting tidal volume, respiratory rate, or inspiratory flow, or administering bronchodilators or diuretics, thereby reducing WOB and improving gas exchange in accordance with evidence-based practice and patient-specific needs. Incorrect approaches analysis, focusing solely on increasing the delivered tidal volume without a thorough assessment of compliance and resistance, is a regulatory and ethical failure. This approach risks overdistending the lungs, leading to ventilator-induced lung injury, VILI, which is contrary to the RRT's duty to provide safe and effective care. It also fails to address the underlying cause of increased WOB, potentially exacerbating the problem. Adjusting the fraction of inspired oxygen, FiO2, without considering the mechanical limitations of the lungs is also inappropriate. While oxygenation is critical, it does not directly address the mechanical factors contributing to increased WOB. This approach neglects the core issue of lung mechanics and may mask underlying problems, delaying necessary interventions. Reducing the respiratory rate without evaluating compliance and resistance is another flawed strategy. While a lower rate can sometimes decrease overall WOB by reducing ventilatory demand, it does not resolve the fundamental issues of lung stiffness or airway obstruction. If the increased WOB is due to high intrinsic resistance or low compliance, simply lowering the rate may not be sufficient and could lead to hypercapnia or inadequate minute ventilation. Professional reasoning. When faced with a patient exhibiting increased work of breathing on mechanical ventilation, the respiratory therapist must employ a systematic, data-driven approach. This involves 1. Recognizing the clinical presentation and its potential implications for lung mechanics. 2. Accessing and interpreting available data, including ventilator waveforms, pressure volume loops, flow time curves, static and dynamic compliance measurements, and airway resistance indicators. 3. Formulating a differential diagnosis for the increased WOB, considering factors affecting compliance, e.g., pulmonary edema, pneumothorax, ARDS, and resistance, e.g., bronchospasm, secretions, endotracheal tube obstruction. 4. Selecting interventions that directly address the identified mechanical abnormalities, prioritizing those that minimize the risk of VILI and optimize patient comfort and gas exchange. 5. Continuously monitoring the patient's response to interventions and making further adjustments as necessary. This process ensures that care is aligned with professional standards, regulatory requirements, and the ethical imperative to provide patient-centered, evidence-based respiratory care. Question 16. Consider a scenario where a patient presents with persistent shortness of breath, wheezing, and sputum production, with a history suggestive of allergic reactions. The RRT is tasked with recommending initial therapeutic interventions. Which of the following approaches best reflects an understanding of the underlying airway inflammation and its management? Option A. Primarily recommend a course of broad-spectrum antibiotics, assuming a bacterial component to the inflammation. Option B. Suggest a trial of antihistamines as the primary intervention, targeting histamine release. Option C. Recommend a trial of inhaled corticosteroids to suppress eosinophilic inflammation and reduce mediator release, alongside a short-acting beta agonist for bronchodilation. Option D. Focus on aggressive administration of nebulized bronchodilators, without further investigation into inflammatory mediators. The correct answer is C. Recommend a trial of inhaled corticosteroids to suppress eosinophilic inflammation and reduce mediator release, alongside a short-acting beta agonist for bronchodilation. Explanation. This scenario presents a common clinical challenge for registered respiratory therapists, RRT, involving the management of airway inflammation, a core competency. The challenge lies in accurately identifying the underlying inflammatory processes and selecting appropriate interventions, which directly impacts patient outcomes and adherence to best practices as defined by the National Board for Respiratory Care, NBRC, content outlines, and relevant clinical guidelines. Careful judgment is required to differentiate between various inflammatory cell contributions and mediator effects to avoid suboptimal or potentially harmful treatment decisions. The correct approach involves recognizing the specific roles of eosinophils and mast cells, and their associated mediators like histamine and leukotrienes, in conditions such as asthma and allergic bronchopulmonary aspergillosis. This understanding guides the selection of therapies that target these specific inflammatory pathways, such as inhaled corticosteroid to suppress eosinophilic inflammation or antihistamines to block histamine's effects. This aligns with the RRT scope of practice, which includes patient assessment, treatment planning, and the administration of respiratory care modalities, all of which must be evidence-based and patient-centered, adhering to the ethical principles of beneficence and non-maleficence. An incorrect approach would be to broadly administer bronchodilators without considering the underlying inflammatory drivers. While bronchodilators provide symptomatic relief by relaxing airway smooth muscle, they do not address the root cause of inflammation driven by eosinophils and mediators like leukotrienes. This failure to target the inflammatory process can lead to persistent symptoms, increased exacerbation frequency, and a delay in effective treatment, potentially violating the principle of beneficence by not providing the most appropriate care. Another incorrect approach would be to focus solely on histamine blockade, without considering the broader inflammatory cascade. While histamine plays a role, leukotrienes are potent bronchoconstrictors and inflammatory mediators, particularly in eosinophilic inflammation. Ignoring their contribution and solely treating with antihistamines would be an incomplete and potentially ineffective strategy, failing to optimize patient care and potentially leading to continued airway compromise, a breach of professional responsibility. Finally, an incorrect approach would be to assume all airway inflammation is identical and to apply a one-size-fits-all treatment. The specific inflammatory cells and mediators involved dictate the most effective therapeutic strategy. Failing to differentiate these processes and tailor treatment accordingly represents a lack of clinical reasoning and can result in ineffective care, potentially leading to adverse patient outcomes and a failure to meet professional standards of care. The professional decision-making process for similar situations should involve a systematic assessment of the patient's clinical presentation, including history, physical examination, and diagnostic data. This assessment should then inform the identification of the primary pathophysiological mechanisms, such as the specific types of inflammatory cells and mediators involved. Based on this understanding, the RRT should then select evidence-based interventions that directly address these mechanisms, continuously monitoring the patient's response and adjusting the treatment plan as necessary. This iterative process ensures that care is both appropriate and effective, adhering to regulatory requirements and ethical obligations. Question 17. Market research demonstrates that respiratory therapists often encounter patients with complex cardiopulmonary conditions where pulmonary vascular resistance, PVR, is a critical determinant of their clinical status. Considering a patient presenting with acute hypoxia and acidemia, which of the following approaches best reflects the respiratory therapist's understanding of factors affecting PVR and their role in patient management? Option A. Assess for and advocate for interventions to correct hypoxia and acidemia, recognizing their direct impact on increasing PVR and right ventricular afterload, while monitoring hemodynamic response. Option B. Focus on bronchodilator therapy to reduce airway resistance and improve ventilation perfusion matching. Option C. Administer supplemental oxygen to improve oxygenation and monitor for changes in respiratory rate and work of breathing. Option D. Initiate non-invasive positive pressure ventilation to reduce the work of breathing and improve tidal volume. The correct answer is C. Administer supplemental oxygen to improve oxygenation and monitor for changes in respiratory rate and work of breathing. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the respiratory therapist to integrate knowledge of complex physiological mechanisms affecting pulmonary vascular resistance, PVR, with the practical application of patient management in a clinical setting. The challenge lies in recognizing how specific patient conditions, such as hypoxia and acidemia, directly impact PVR and, consequently, the patient's hemodynamics and oxygenation. Furthermore, understanding the underlying causes of pulmonary hypertension is crucial for effective treatment planning and patient advocacy, demanding a nuanced approach that goes beyond simple symptom management. The respiratory therapist must act as a critical member of the healthcare team, interpreting data and contributing to decisions that directly affect patient outcomes. Correct approach analysis. The correct approach involves recognizing that hypoxia and acidemia are potent vasoconstrictors of the pulmonary vasculature. Hypoxia triggers the hypoxic pulmonary vasoconstriction reflex, increasing PVR to redirect blood flow to better ventilated lung regions. Acidemia, particularly respiratory acidosis, also leads to pulmonary vasoconstriction, further elevating PVR. In the context of pulmonary hypertension, these factors exacerbate the existing elevated pressures, worsening right ventricular afterload and potentially leading to right heart failure. A respiratory therapist's role is to identify these contributing factors, advocate for interventions to correct them, e.g., optimizing ventilation, administering bronchodilators or vasodilators as prescribed, and monitor their impact on PVR and overall hemodynamics. This aligns with the RRT scope of practice, which includes assessing, treating, and managing patients with cardiopulmonary disorders, and adhering to established clinical practice guidelines and ethical principles of patient care. Incorrect approach is analysis, an approach that focuses solely on administering oxygen without considering the potential for worsening PVR in certain conditions, e.g., chronic lung disease with established pulmonary hypertension, is incorrect. While oxygen is vital, excessive or inappropriate oxygen therapy can sometimes have unintended consequences on pulmonary hemodynamics, especially in the presence of underlying pulmonary vascular disease. This fails to address the multifaceted nature of PVR regulation and the potential for iatrogenic harm. Another incorrect approach would be to disregard the impact of acidemia on PVR and focus only on other potential causes of dyspnea. Acidemia directly contributes to increased PVR and right ventricular strain. Ignoring this physiological insult means failing to address a significant factor contributing to the patient's condition and potentially delaying appropriate interventions like ventilatory support to correct the acidosis. Finally, an approach that attributes all elevated pulmonary pressures solely to intrinsic lung disease without considering other contributing factors like left heart failure or thromboembolic disease is incomplete. While intrinsic lung disease is a common cause of pulmonary hypertension, a comprehensive assessment requires considering all potential etiologies to ensure the most effective and targeted treatment strategy. This demonstrates a failure to conduct a thorough differential diagnosis and a lack of critical thinking in patient management. Professional reasoning. Respiratory therapists should employ a systematic approach to patient assessment and management. This involves 1. Thoroughly assessing the patient's cardiopulmonary status, including vital signs, arterial blood gases, and hemodynamic parameters. 2. Identifying physiological derangements that directly influence PVR, such as hypoxia, hypercapnia, and acidemia. 3. Considering the patient's underlying conditions and potential etiologies of pulmonary hypertension. 4. Collaborating with the healthcare team to develop and implement a treatment plan that addresses the identified factors and aims to reduce PVR and improve patient outcomes. 5. Continuously monitoring the patient's response to therapy and adjusting interventions as needed. This process ensures that patient care is evidence-based, patient-centered, and aligned with professional standards and ethical obligations. Question 18. The investigation demonstrates a bronchoalveolar lavage sample from a patient presenting with chronic cough and excessive sputum production. Microscopic examination reveals a significant increase in the number of goblet cells, with some evidence of goblet cell hyperplasia. Considering the primary functions of airway epithelial cell types, which of the following therapeutic strategies would be most appropriate to address the observed cellular changes and patient symptoms? Option A. Increasing the patient's supplemental oxygen delivery to improve gas exchange, as the increased cell count suggests a general inflammatory process impacting oxygenation. Option B. Recommending a course of broad-spectrum antibiotics to combat a potential underlying bacterial infection contributing to the increased cellularity. Option C. Initiating bronchodilator therapy to reduce airway inflammation and bronchospasm, as the primary issue is likely smooth muscle constriction. Option D. Administering mucolytic agents to thin, tenacious secretions and facilitate expectoration, alongside interventions to optimize mucociliary clearance. The correct answer is D. Administering mucolytic agents to thin tenacious secretions and facilitate expectoration, alongside interventions to optimize mucociliary clearance. Explanation: this scenario is professionally challenging because it requires the respiratory therapist to integrate knowledge of cellular biology with the practical application of diagnostic and therapeutic interventions. Misinterpreting the function or location of specific epithelial cell types can lead to incorrect patient assessment, inappropriate treatment choices, and potentially adverse outcomes. Careful judgment is required to accurately correlate observed cellular changes with underlying pathological processes and to select interventions that specifically address the compromised cellular functions. The correct approach involves accurately identifying the predominant epithelial cell type observed in a bronchoalveolar lavage sample and correlating its known function with the patient's clinical presentation and symptoms. For example, an increased presence of ciliated cells with impaired motility might suggest a condition affecting mucociliary clearance, necessitating interventions to mobilize secretions. Similarly, an abundance of goblet cells could indicate hypersecretion, requiring mucolytic agents or suctioning. This approach aligns with the RRT scope of practice, which mandates the application of scientific principles to the assessment, treatment, and management of cardiopulmonary disorders. Regulatory frameworks for respiratory care emphasize evidence-based practice and the accurate interpretation of diagnostic data to guide patient care. An incorrect approach would be to focus solely on the quantity of cells, without considering their specific type and function. For instance, simply noting a high cell count without differentiating between ciliated, goblet, basal, or Clara cells would provide insufficient diagnostic information. This fails to leverage the specialized knowledge required for effective respiratory care and could lead to a generalized, rather than targeted, treatment plan. Another incorrect approach would be to assume that all epithelial cells in the airway perform the same function, ignoring the distinct roles of each cell type. This demonstrates a fundamental misunderstanding of airway physiology and would result in an inability to diagnose or treat conditions that specifically impact certain cell populations, such as the mucociliary escalator dysfunction caused by impaired ciliated cells or the excessive mucus production associated with goblet cell hyperplasia. A further incorrect approach would be to attribute functions of one cell type to another. For example, assuming basal cells are primarily responsible for mucus secretion, when that is the role of goblet cells. This misattribution would lead to diagnostic errors and inappropriate therapeutic strategies. Professional decision-making in such situations should follow a systematic process. 1. Thoroughly review the patient's clinical history, symptoms, and current status. 2. Analyze diagnostic data, such as bronchoalveolar lavage findings, with a focus on identifying specific cellular components and their potential implications. 3. Correlate cellular findings with known physiological functions and pathological processes. 4. Select interventions that are evidence-based and specifically address the identified cellular dysfunction and its clinical consequences. 5. Continuously monitor the patient's response to therapy and adjust the treatment plan as needed. Question 19. The analysis reveals a patient presenting with shortness of breath and hypoxemia. Arterial blood gas (ABG). Results show a PaO2 of 55 mmHg and a PaCO2 of 40 mmHg. The calculated alveolar partial pressure of oxygen, PaO2, is 100 mmHg. Based on these findings and adhering strictly to the regulatory framework for registered respiratory therapists in the U.S., which interpretation best guides the next steps in patient management? Option A. The significant gradient between PaO2 and PaO2 suggests a ventilation perfusion, V/Q, mismatch or intrapulmonary shunting, necessitating further investigation into the cause of impaired gas exchange and potential adjustments to oxygen therapy or ventilatory support. Option B. The normal PaCO2 indicates adequate alveolar ventilation, and the hypoxemia is likely due to a diffusion defect, requiring only an increase in supplemental oxygen. Option C. The normal PaCO2 implies that the patient's respiratory drive is intact, and the hypoxemia is a transient issue that will resolve with rest. Option D. The low PaO2 is the primary concern, and the focus should be solely on increasing the fraction of inspired oxygen, FiO2, until the PaO2 reaches a target of 80-100 mmHg, without further analysis of other ABG values. The correct answer is A. The significant gradient between PaO2 and PaO2 suggests a ventilation perfusion, V/Q, mismatch or intrapulmonary shunting, necessitating further investigation into the cause of impaired gas exchange and potential adjustments to oxygen therapy or ventilatory support. Explanation: this scenario is professionally challenging because it requires the respiratory therapist to interpret complex physiological data, partial pressures, in the context of a patient's clinical presentation and to make critical decisions that directly impact patient care and outcomes. The therapist must balance the need for accurate assessment with the urgency of the patient's condition, ensuring that interventions are evidence-based and aligned with established standards of practice. The correct approach involves recognizing that a significant discrepancy between alveolar and arterial partial pressures of oxygen, PaO2 and PaO2, indicates impaired gas exchange, likely due to a ventilation perfusion, V/Q, mismatch or intrapulmonary shunting. Similarly, an elevated PaCO2 with a normal or low PaCO2 suggests inadequate alveolar ventilation. The respiratory therapist's responsibility, as outlined by the National Board for Respiratory Care, NBRC, Registered Respiratory Therapist, RRT, credentialing standards, is to interpret these values in conjunction with clinical findings to identify the underlying cause of the patient's respiratory distress and to recommend or implement appropriate therapeutic interventions. This aligns with the ethical obligation to provide competent and safe patient care, prioritizing patient well-being, and advocating for necessary treatments. An incorrect approach would be to solely focus on the PaO2 value without considering the PaCO2 and the clinical context. This fails to recognize that hypoxemia can have multiple etiologies, and a low PaO2 alone does not pinpoint the problem. Another incorrect approach is to assume that a normal PaCO2 automatically signifies adequate ventilation, even in the presence of hypoxemia, as compensatory mechanisms can mask underlying ventilatory issues. Furthermore, ignoring the alveolar partial pressure of oxygen, PaO2, and only looking at the arterial oxygen saturation, SpO2, or PaO2 is a critical error, as the PaO2 provides a baseline for assessing the efficiency of oxygen transfer from the alveoli to the blood. Relying solely on subjective patient complaints without objective data from blood gas analysis is also professionally unacceptable, as it bypasses the essential diagnostic tools available to the therapist and deviates from evidence-based practice. The professional decision-making process for similar situations involves a systematic approach. First, gather all available data, including patient history, physical assessment, and laboratory results, such as arterial blood gases. Second, interpret the data in a holistic manner, considering the interplay between different physiological parameters. Third, formulate a differential diagnosis for the observed abnormalities. Fourth, consult relevant clinical guidelines and evidence-based literature to inform treatment decisions. Finally, communicate findings and recommendations clearly to the healthcare team and implement interventions with continuous monitoring and reassessment. Question 20. The audit findings indicate a pattern of delayed recognition of central hypoventilation in patients presenting with altered mental status and hypoxemia. A respiratory therapist is reviewing a case where a patient presented with a decreased level of consciousness, shallow respirations, and an ABG revealing a PaCO2 of 55 mmHg, pH of 7.25, and PaO2 of 60 mmHg on room air. Which of the following interpretations best reflects the primary neural control mechanism likely impaired in this scenario, guiding subsequent therapeutic decisions? Option A. The primary issue is likely a failure of the peripheral chemoreceptors to detect the rising PaCO2 and stimulate increased ventilation. Option B. The primary issue is likely a severe bronchospasm that is preventing adequate gas exchange, despite intact respiratory drive. Option C. The primary issue is likely a failure of the central chemoreceptors to respond to the elevated PaCO2, leading to a loss of ventilatory drive. Option D. The primary issue is likely a failure of the respiratory centers in the medulla and pons to adequately stimulate the respiratory muscles, leading to hypoventilation and subsequent hypoxemia. The correct answer is D. The primary issue is likely a failure of the respiratory centers in the medulla and pons to adequately stimulate the respiratory muscles, leading to hypoventilation and subsequent hypoxemia. Explanation: scenario analysis. This scenario is professionally challenging because it requires the respiratory therapist to interpret complex physiological data, arterial blood gas results, and patient presentation, in the context of potential dysregulation of the brainstem's respiratory centers. The challenge lies in differentiating between primary respiratory center dysfunction and secondary effects from other physiological derangements, necessitating a thorough understanding of neural control mechanisms and their clinical manifestations. Accurate assessment is critical for appropriate intervention and patient safety, as misinterpretation could lead to delayed or incorrect treatment. Correct approach analysis. The correct approach involves a systematic evaluation of the patient's clinical presentation alongside the arterial blood gas (AB) results to infer the underlying cause of the altered respiratory drive. Specifically, recognizing that a normal or near-normal PaCO2 with a significant decrease in PaO2, coupled with signs of hypoventilation and a history suggestive of central nervous system depression, points towards a problem with the respiratory center's ability to stimulate breathing. This aligns with the understanding that the medulla and pons are responsible for generating the respiratory rhythm and responding to chemical stimuli. The failure of these centers to adequately signal the respiratory muscles would result in hypoventilation and subsequent hypoxemia, even if peripheral chemoreceptors are attempting to compensate. This approach prioritizes understanding the fundamental neural control of respiration, as mandated by RRT practice standards, which emphasize the application of physiological principles to patient care. Incorrect approaches analysis. One incorrect approach would be to solely focus on correcting the hypoxemia with supplemental oxygen, without investigating the underlying cause of the hypoventilation. This fails to address the root problem of impaired respiratory drive, potentially masking the severity of the central nervous system issue and delaying appropriate management. It neglects the critical role of the respiratory centers in maintaining adequate ventilation. Another incorrect approach would be to attribute the hypoventilation solely to peripheral chemoreceptor dysfunction, without considering the primary role of central chemoreceptors and brainstem centers. While peripheral chemoreceptors are important, their primary role is to respond to significant changes in PaO2 and pH, whereas central chemoreceptors, located in the medulla, are the primary regulators of ventilation in response to changes in PaCO2 and pH. A primary failure of the respiratory centers would override or significantly impair the response of peripheral chemoreceptors. A third incorrect approach would be to assume that any patient with hypoxemia and hypoventilation must have a primary pulmonary disease, and to initiate aggressive bronchodilator therapy or mechanical ventilation, without first assessing for central causes. This overlooks the possibility of neurological impairment affecting respiratory control, which would not be addressed by pulmonary-specific interventions. Professional reasoning. Respiratory therapists should employ a problem-solving approach that begins with a comprehensive assessment of the patient's clinical status, including vital signs, level of consciousness, and physical examination findings. This should be followed by a thorough review of laboratory data, such as ABGs, to identify physiological derangements. When interpreting ABGs, it is crucial to consider the interplay between ventilation, PaCO2, and oxygenation, PaO2, and how these relate to the patient's clinical presentation. Understanding the hierarchical control of respiration, with the brainstem centers being the primary drivers, is essential. If hypoventilation is present, the therapist must consider potential causes, including central nervous system depression, neuromuscular blockade, or intrinsic respiratory muscle fatigue, and then tailor interventions accordingly, prioritizing the most likely and critical etiologies.